This is life. A moment of joy. A dream come true. All pure love. A tiny breakthrough. Or maybe a triumph. A constant struggle. A clash of ideas. We can make a difference. Create the new, the unexpected. Leading us to feel great, strong, or simply human. Constantly questioning, are we curious enough? Could we be closer? Can we? Can you feel it?
To start. I also apologize for inability to start exactly by 1 p.m. Unfortunately, in our environment, we always make reference to African time, much more in a city like Lagos. Somehow understandable. Now, we appreciate all of you, people that came from outside the country, from outside Lagos, and all those that are hosting us in Lagos here. We appreciate you. This is a drug launch. I want you to relax.
Recording in progress.
It will be very insightful.
It will be very enjoyable experience. We have erudite speakers. We have erudite moderator. We have erudite experts, cardiologists from within and outside Lagos. I believe that why we have gathered here today is just simply in the interest of the patients. And at the end of the day, you will appreciate why. Relax. As at the appropriate time, you will know all the people that will be anchoring this event. They'll be appropriately introduced. And at this juncture, I want to hand over to the organizer. Thank you.
So, good afternoon, everyone. Are we ready? Okay. So it gives me special joy to welcome everyone here today. My name is Charles Ajibo. I am the country manager for MEC. I am very happy that you have created time today for us to care for our patients. We know that in these days, especially in Lagos, it is not very easy to be able to move around because of the craze around the fuel scarcity and all kinds of queues. But for you to have found time today, it's something that we deeply appreciate because it shows the commitment that we all have for our patients in the society. I'm going to be able to just say a few words, but my major task is to tell you welcome and to ask you to listen, relax, so that we can share knowledge. We have been able to bring a couple of experts together, and we want to make sure that we transfer knowledge to everyone around the room today. And we want to also show you that in life, sometimes it's not always for us to, it's not always predictable. 1 + 2 today is not going to, 1 + 1 today is not going to be 2. We are going to show you today that 1 + 1 is going to be equal to 3 and can actually be equal to 4, depending on how you're going to understand it today. So I'm going to throw a few posers around as we discuss. So let's go. Works? Okay, good. So let's speak about MEC for a few moments. As we are today, we are a middle-sized company in the world. We can't say we are one of the biggest pharma, but our revenues as about 2021 is in the neighborhood of about 18 billion euros. So this is as about 2016 that we are showing, but in 2021, end of 2021, we're already about 18 billion euros. And we happen to be the oldest pharmaceutical company in the world. And it's something that perhaps gives us some ways of trying to say how resilient we have become as a company. The company was started in 1668, so it's about 354 years today. It was started as a normal pharmacy. Yeah, thanks for that, yeah. It was started as a normal pharmacy and transformed into a manufacturing and a middle-sized company. We employ over 50,000 people all across the world. We have physical offices in over 66 countries of the world. And we plow back a lot of money into R&D. I think as about 2021, it's about 2.4 billion euros that is being plowed back into R&D from the profits that we make. We are not just a pharmaceutical company, actually. A lot of people maybe have not taken time to understand this. We are a science and technology company. Our businesses are not just healthcare only, even though that's what brings us and you together. It's a family-owned company, but also publicly quoted. And maybe a bit of why it's very agile, perhaps, is that it's not completely publicly quoted. It's 70% family-owned and 30% publicly quoted. Most of the publicly quoted companies go through more pressures for shareholder returns, and they are not able to maybe withstand headwinds and difficulties most times. So we see most people know about this. Sorry, you took it up? Okay, that's fine. Most people know about this, and I wanted to actually emphasize this. We started, like I said, 354 years in Germany, a city called Darmstadt, and then people moved into the US from that same family-owned business, started a US subsidiary. Then at the end of when the World War broke up, you can see MEC opened an office in New York. Then after 3 years after the World War started, that particular company, a lot of German investments in the US were actually taken over by the US authority. And then it no longer belonged to us. It now became MEC Sharp and Dome. So there is a bit of, I would say, a relationship that we had with MEC Sharp and Dome. We were one company before. Then when they broke away from us because the US had taken over the company, it became MEC Sharp and Dome, and now it's called MSD. So we are not MSD. Don't ever make that confusion. We have MEC, they are MEC, Sharp and Dome, and they had a right. There was a discussion and a legal dispute on how do we answer the name, so it was agreed that we should answer MEC all over the world except the US and Canada. So they answer MEC in the US and Canada, and they answer MEC, Sharp and Dome everywhere else in the world. So that's the distinction. So we are here as MEC. If there is an office of MEC, Sharp and Dome in Nigeria, they will actually answer MSD, they will not answer MEC. But because a lot of Nigerians are affiliated to the US, it's always confusing for a lot of people because most of us go to the US and the UK, and in the US they are allowed to answer MEC, but in the UK they answer MEC, Sharp and Dome. So it's important to say that. Okay, so this is what I was dwelling on. We have three core areas: the healthcare, where we have various products and we are proud of the level of partnership and the care we provide for patients. If I ask around the room today, how many babies do you think have come into the world because of our solutions in ART? We are world leaders in fertility and assisted reproduction. A lot of you may know that. We are proud to say that over 3 million children have been born. Yes, all over the world, over 3 million children have been born because of our innovation and our ingenuity. If I speak about how we help to prolong the lives of patients and improve the quality of life, as about last year, 2 billion tablets of Concor is what we have manufactured and we're serving patients all across the world. If I look at it, I have on record that 120 million patients all over the world swallow glucophage, either glucophage or glucophage XR. And about 30 million patients around the world swallow Concor or maybe Concor AM. And in some markets, it is the clear market leader. If you go around the Middle East and Gulf, they don't actually even have a lot of other molecules we use here as their best,
Recording in progress.
As their best agents. So we are happy that as a company, we are supporting life. We are improving the quality of life of patients. And for people who have cancer, either metastatic colorectal cancer or head and neck, our product Erbitox had been seen very useful, prolonging lives of patients, giving grandparents the opportunity to spend quality time with grandchildren before they will finally bow out. If you look at life sciences, which is another big arm of our business, this is where we do a lot in terms of research, in terms of also making life science tools, diagnostic tools, research for regulatory agencies, laboratories, university research companies. And when you look at performance materials, most people don't know that how bright the world is today came as a result of our research. We are the world leader in high-tech liquid crystals. So we make you see bright TV. We make you see bright things on the phone that you're holding. It is the research that's provided the very high resolution displays. And we also make effect pigments that are used in the car industry for paints and also specialty chemicals for semiconductor industry. So I would not dwell on the life science because that's not what you are here to discuss today. I'll quickly move on to say that performance materials may also apply for that environment. But let me also now move to say that why are we still able to remain strong and standing after 350 years? It is because at every point in time, we are trying to innovate. We are trying to bring superior solutions to the market. And I can give you some examples. We brought in glucophage as an instant release product, and we found out from research that extended release would be more tolerated by the patients, would also provide better care. And we moved on to bring extended release. Look at today, we are discussing Concor and Concor AM. We brought in Concor to you, and we now found out that in some cases you require a second agent. And we are happy also to bring you Concor AM because we believe that we are equipping you with the right tools for you to be able to care for the patients better. So we're a company that we are proud about the innovation we have brought to life, and we are happy to partner with you. say thank you very much for this short intro, and then let's really relax, because I came here to learn from the experts, and I believe you're also going to learn too, and we can have a great day together. Thank you very much.
Well, good afternoon. Yani it's really a great pleasure to be here with you in Nigeria. I wanted to start with the video of the heart rate, and there is a reason for this. Echoing what Charles was sharing, which is 1 + 1, not usually as logic mathematical equals to, because in math, we speak about logic and we speak about numbers, but in biology, sometimes it may be different. This is why I started with the video of the heart rate to show how important heart rate is. Previously, I think in indications, you are more expert in seeing that the heart rate is critical in ischemia, and there was a target for ischemia, which is 60 beats per minute. But nowadays, starting from 2018, there was a change in the guidelines, the European Society of Hypertension and Cardiology. And we found that they have set a target for heart rate even for hypertension, which is 80 beats per minute. So the heart is a crucial part regarding the hypertension. And then I go back to the journey of the product itself, the journey for Concor, because it's a kind of linked to me in a way. Any one of you know when Concor in general was there in the world? What year? In what year? Just give a guess. What year Concor was available in the world? Any guess? 2000, 10 years ago. This is an option. So 10 years ago, so it was 2010, right? Any other guess? 19 something? Actually, Concor was found in the world in 1986. So it's the same age as myself because I was born in 1986. So this is why there is a link. Thank you, Charles. So we have been seeing this for long years performing and going with the heart. And if you see that in 2018 only, we have seen that in the guidelines, the heart rate have been placed. However, since 1986, we have been promoting the Framingham study, the Bennett study, showing the importance of the heart rate. And finally, what we have been sharing about the importance of heart rate have been stated in the guidelines. To move forward with this journey, also, we needed to move that hypertension is a progressive disease. So if we move with Concor as monotherapy, when you go to stage 2 hypertension, of course, the equation will be different. And when you see that you need the combination therapy, in the market, you will see triple combinations, and sometimes you need even quadruple combinations. Why I shared the video in the beginning, it's always about the root cause of hypertension. Like, for example, if we speak about flu or about common cold, and the person goes to get an antibiotic, broad spectrum antibiotic, he will get controlled, right? He will get controlled. But if you make a culture and if you see it's a gram positive or a gram negative and give the specific antibiotic, he will get controlled, yes, in good timing, and he will not develop resistance. The same applies for hypertension. It's not even related to race like black and white. And of course, this will be tackled in today's presentation because it's about manifestation of the disease, whether his heart rate is high or low, stage 1 or stage 2 hypertension. And it will be ideal if there is a high heart rate to use a combination that will give you combining dual combination to reach 3 modes of action, to reach 3 ways of control, rather than putting triple combination from stage 2, and finally we'll end up just tackling 2 mechanisms of actions. So through this day discussion and through this day launch, you will see that 1 + 1 really not equal to, it can equal 3 and even more. It's according to what you are combining, because here we are speaking about biology and human response, not just mathematics. And here I'm really glad to announce that today in the country, there will be Concor AM, the 5.5 and the 5.10 in the country. And the upcoming couple of days, maximum a week, it will be available at the channels and the pharmacies. And now, without further ado, I will give, of course, the floor to our today's moderator, Dr. Yemi Johnson, the founder of First Cardiology, to give introduction to our esteemed speakers for today. Thank you.
Right. Good afternoon, everybody. I have a very easy job to do. I'm just to introduce the two speakers, and it's like master of ceremony of a wedding. So this shouldn't be too hard. First of all, our speaker, before we go into anything academic, I have to explain something about our first speaker. He's from Poland. And we have to finish this conference on time because they have a match against Argentina. You know, this World Cup matter is serious for them, us, all of us. So listen carefully, imbibe what it says. If they win, if Poland wins, there's a special bonus for us after. So, okay. So introducing our first speaker, I hope I pronounce his name correct, Professor Zbigniew Garsion from Warsaw. His CV is long, several pages, so we'll just give you a brief intro here. Anyway, he is the chairman of Department of Internal Medicine, Hypertension, and Vascular Diseases in Medical University of Warsaw, which happens to be the biggest reference center for hypertensive patients in the country. He is now also the president of the Medical University of Warsaw. He's been president since 2020. And as you can see, he comes highly recommended. So I'm not going to spend too much time on his CV because we want to listen to what he has to say. The title is 1 + 1 = 3. That's not a difficult concept for us here. This is just like INEC. So we shouldn't have any trouble understanding him. So Prof, would you please come up? And then there's going to be some polls, some question taken. So he's going to ask some questions. Scan your phone on the QR code on the table, and then you can answer the questions. Please, it is important you answer the questions so we understand if the lecture has made sense to us. Thank you.
Yes, good afternoon. Thank you very much, Dr. Johnson, for your very kind introduction. And as you have already mentioned, in medicine, okay. In medicine, we don't use simple maths. So sometimes 1 + 1 does not equal 2. And in particular, when it comes to treatment of high blood pressure, as we are all aware, it's a #1 all over the world major cardiovascular risk factor contributing to. Sure.
Oh, thank you so much.
Okay. Okay, thank you. Thank you. I'm sorry. Now, can I be heard? It's okay? Sorry. Should I repeat everything? So let me just say thank you very much, Dr. Johnson, for your very kind introduction, and I will follow. Okay, so we know that in medicine, we don't deal with simple maths, and 1 + 1 does not necessarily equal 2. Sometimes, particularly in the treatment of hypertension, you can get an additional benefit of advantage of certain combinations of blood pressure lowering medications. And as you all know, the major topic for today and the celebration of the introduction of Concor AM to Nigeria is combination of beta blocker, a calcium channel antagonist. And usually now, particularly nowadays, some people have some concerns about the treatment for beta blockers. And I would like to address all these concerns during my talk. And also I am ready to answer any additional question and discuss any issue that is related to so-called another side of beta blockers. But let me start from the first question directed to you. If you are reluctant to prescribe a beta blocker to your patient, what is your major concern? Are you afraid of glucose intolerance or hyperlipidemia, the effect on mood, depression, or, for example, aggravation of peripheral artery disease? Okay, if you could vote, we will see what is the major problem here. Okay. Okay, so we'll see, I think, very soon. Next, fixed dose combination is a mainstay of a treatment of high blood pressure. And this is because of many advantages that are offered by combining selected drugs. In your opinion, what is the most important advantage? What is, in your opinion, a major benefit of prescribing fixed dose combinations? You have four possibilities presented here. Is it because these combinations are better tolerated? This is because of combination, they are more efficient in lowering blood pressure, they offer better patient's compliance, or they are preferred by a patient. What is your experience with FDC? What is your personal opinion? Please vote. And the third question, I'll be talking, and also in another talk, there will be a lot of information about so-called sympathetic overdrive. So in hypertension, and as well as in other diseases, we have an elevated basal tone of sympathetic nervous system that we call sympathetic overdrive or adrenergic overactivity. Hypertension is one example. However, we have other diseases where we come across this phenomenon. Will you mark those who you think are associated with sympathetic overdrive? Please note that you have also an option that all of them can be associated with sympathetic overdrive. Okay, we have answers. I will have to go to the other side of the stage. Okay, so when it comes to your major concern for prescription of beta blockers, it's mostly fatigue. No. Okay, so it's mostly fatigue and risk of diabetes. I'll be happy to address these issues later on. As a major advantage for FDCs, you see better adherence of patients. That's the very important point, because drugs only work if patients take them. If they don't swallow drugs, there's no chance that they will be working. And let's see the third question. More than half of the audience is pretty sure that sympathetic overdrive is associated with all of the clinical conditions listed. Please let me emphasize that all these clinical situations, hypertension, obesity, chronic kidney disease, or sleep apnea are very common nowadays, and in particular, due to the obesity pandemics, the percentage of subjects with sleep apnea, with hypertension, is increasing all over the world. During last 20 years, we have 500 million of new hypertensive patients all around the world. Okay, so let me offer you an evidence that in medicine, simple maths doesn't work, and sometimes 1 + 1 may be more than 2. So, oops, 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 oops. Can you do something with? Okay. So we have 10-year experience around the world with the combination of bisoprolol and amlodipine, and this experience has been summarized in a book, which has been just recently released. So definitely Merck representatives can offer you a copy of this book very soon. But let's go back to the major subject. So combination of bisoprolol and amlodipine. Nowadays, and it's a statement which is included in all guidelines all around the world, either international guidelines, European, American, national, local guidelines. They clearly say, if you have a patient with hypertension, for more than 80% of patients, you will not control blood pressure with a single drug. So you have to combine different medications, and we have 5 major antihypertensive drug classes. And this is a quote from European guidelines. And please remember that in this group of major class, beta blockers are included. Why we have to combine different drugs? Because essential hypertension is not a single disease. It's not one process that raises blood pressure. It's a combination of different mechanisms, like activation of adrenergic centers in the brain, vasoconstriction of arterioles, increased resorption in sodium and water. Okay? So there are many, many mechanisms, and we have to target all of them to be successful in preventing cardiovascular complications. Here you see the example. You see here the acronyms for well-known clinical trials. In the brackets, you can see a target systolic blood pressure that was achieved during the treatment. And as you can easily notice, to get to this pressure, all patients had to be treated with 2 drugs. Majority of them required 3 different medications to get to the goal blood pressure. And we know that if you have a patient who is not controlled on monotherapy, you have 2 options. You can up titrate the dose of a given drug, or you can add another drug of a different class. And the second option is 5 times more effective, as you can see here. Doesn't matter what kind of drug you add, if it comes from a different group of antihypertensive medications, the blood pressure reduction is 5 times higher as compared to doubling the dose of an existing drug. So combination is necessary for control of blood pressure almost in all of our patients. Combination in the form of fixed dose combination provides you with another advantage. You mark a better patient compliance as #1 benefit of fixed dose combination. And we know if you reduce the number of pills the patient has to take, you improve patient's compliance. There's a significantly higher chance that the patient will follow your advice, that the patient will take a drug prescribed, which of course translates into better blood pressure control. And you see here, when you reduce number of medications, you increase the chance of better control of the disease. So we have a combinations as the mainstay of the treatment of hypertension. And we have also rules how to combine the drugs in the most effective way. You have these rules listed here, but the major rule is that the combination should offer some additional advantage. Drugs should present a different mode of actions, and preferably, they also should minimize the potential adverse effect. So, for example, if you give a patient an amlodipine, which is a dihydropyridine calcium channel antagonist that may increase heart rate, but when it's combined with bisoprolol, a beta blocker, this reflex tachycardia is limited or even reduced. And you see here that there are many mechanisms for both bisoprolol and amlodipine to reduce blood pressure, and these mechanisms are complementary one to another. Please also know that beta blockers, bisoprolol included, are also inhibitors of renin-angiotensin system because beta-1 receptors are present on the renin-secreting cells in the kidney. So when you block beta-1 receptors, you reduce renin activity in blood, and of course, you reduce activity of angiotensin, renin-angiotensin aldosterone system. So in a way, beta blockers can be considered a RAS inhibitor. So this is another mechanism for blood pressure reduction and also organ protection. Nowadays, when we talk about drugs, the efficacy, the advantages, the indications for clinical use, you always ask the question, how about studies with clinical endpoints? Do we have an evidence that comes from controlled trials with the combination of beta blocker and calcium channel antagonists? And I can tell you that there is no such a trial that included this particular combination that was compared with different treatment regimens. However, when you look at the clinical trials with drug combinations, basically we have only one clinical trial that used pre-specified combinations of blood pressure lowering drugs. I'm talking about accomplished trial which compared ACE inhibitor with either diuretic or calcium channel antagonist. But we can look at the data from different clinical trials to check the patients who were on beta blocker and calcium channel antagonists, whether this combination was equally effective as other drugs used in this trial. First of all, let me show you a data from meta-analysis where beta blockers were analyzed as the second option drug. So they were added to the existing treatment of hypertension. As you can see here, they're highly effective, dose-related when it comes to blood pressure reduction. Also, let me remind you an old trial, the HOT trial. As I look at the audience, probably are too young to remember HOT trial because the trial ended by the 20th century. And this was the first trial where patients were randomized into 3 groups. And the randomization was into different blood pressure levels. At the 20th century, we are more interested in diastolic than into systolic blood pressure. So these 3 groups should be treated to diastolic blood pressure below 80, below 85, and below 90 millimeters of mercury. But what you can see from this trial that if you look at the optimal blood pressure, you see that is around below 140 and below 80, below 85 millimeters in mercury for the entire group. The significance was noted in patients with diabetes. That's why in previous guidelines for diabetics, there were different target blood pressure levels. However, in the HOT trial, the major drug that was used as an initial therapy was felodipine, calcium channel antagonist. And as you can see here, most of the patients required an addition on another drug to get to their target blood pressure. And you see that if you want to get better blood pressure control, to get below 80 millimeters of mercury, you had to add another drugs, and beta blockers were also included. And the amount of patients who were treated with beta blockers was increased according to the target blood pressure. Let me again remind you that for diabetics, those who had diastolic below 80 millimeters of mercury, there was a lower cardiovascular risk as compared to higher blood pressure levels. But of course, if you have one pill with two different molecules, first, you have to be sure that there's no interaction between these two molecules, either in the process of pharmaceutical formulation or in the bioavailability, absorption, and also the effect at the target organs. So usually when you develop a new medication, you start from pharmacokinetics. And here you see that regardless, bisoprolol and amlodipine are given separately as two separate pills or as a one pill. The plasma levels of each molecules are practically identical. So there's no interaction between these two molecules. So in this term, it's a perfect combination. But also we have data. We have data on Concor AM that show the efficacy in the treatment of blood pressure. And let me review those data for you. You have them listed here in the table, and I will stop and discuss selected trials from this list. First of all, if you start to treat patients with hypertension with a combination, it's not working. It's not working. I can hear my, okay, sorry. No, it's okay. No, you want me to use, okay. But it's not on. Can you hear me? Okay, now it's better. Okay. Yeah, can you hear me? Okay. From which slide I have to start again? No? No, I can go back to the very beginning. I'll be happy to start over. Oh, okay. No? No, someone said, yes, please start over. No? Okay. Okay. So when you start to treat patients with hypertension with a combination from the very beginning, and you take just a low dose of bisoprolol and amlodipine, these combinations are available in Nigeria pretty soon. So you see that you can quickly achieve very good blood pressure control. You have a reduction of 4 weeks of blood pressure by at least 30 millimeters of mercury systolic. So this is a very good efficacy. Also, please note that heart rate is reduced. And we'll be talking about heart rate as a measure of sympathetic overdrive. And it's important to control heart rate, which is an independent cardiovascular risk factor. Also, let me show you another data. These are observational studies based on the database that included almost 15,000 patients with hypertension who were switched from 3 combination into single pill combination of bisoprolol and amlodipine. As you can see here, when you look at the difference in persistence and compliance, there's a tremendous benefit on the side of FDC, of Concor AM. Compliance means the percentage of pills that patients take a day or a selected period of time. And usually, if you have compliance over 80%, is considered an excellent compliance or very good compliance. Persistence means that the patient remains in the treatment. And as you can see here, you have more than 50% of patients who were still taking FDC, Concor AM, and also they accepted 3/4 of the prescribed doses, which is very close to a very good compliance. When you compare it to a single pill combination, these figures are dramatically low, dramatically low. 1 in 10 remained in the treatment after 1 year. Also, let me show you some data on compliance and efficacy of hypertensive treatment coming from prospective observational studies, like this study that also included more than 10,000 patients with high blood pressure. And this is your typical patient. Slightly overweight, uncontrolled blood pressure, long-term history of hypertension, treated with different drugs in the past, as you can see, not effectively, not on the target blood pressure, also with coexisting comorbidities like diabetes, history of coronary heart disease, and unfortunately, a lot of them were smokers, and also they regularly drank alcohol. So this is typical patient with a little bit low chances or lower chances for very good compliance and persistence. So let's look how the change to FDC for Concor AM affected the compliance. And as you can see here, the compliance improved tremendously. I told you that the criterion for very good compliance is 80%. So the number of patients who presented with very good compliance was more than 90%. So very simple move, practically effortless. You write one prescription, significantly changes patient attitude toward treatment. And you have much better blood pressure control. You see the difference in terms of systolic and diastolic blood pressure after 6 months of the trial, and which is not unexpected, the degree of blood pressure reduction is strictly correlated with the level of compliance. And as you can see here, so better compliance translates into better blood pressure control. And from the same study, you can see that this effect can be also observed in special populations of patients, like subjects with diabetes, subjects with the history of cardiovascular disease, subjects with chronic kidney disease. Also, we have few trials, some of them are ongoing, prospective trials, randomized, carried out in the double-blinded fashion. So the patients were treated either in an active substance or a placebo. Let me show you the data of our trial. The trial has been completed. It's about to be published. This was the trial. There were patients uncontrolled of the single dose of amlodipine were randomized either to combination with bisoprolol or to amlodipine plus placebo. This is the flow chart for patients. Almost 400 patients were included into the trial. And as you can see here, those patients were typical subjects with high blood pressure, uncontrolled hypertension, and also please note that many of them had a heart rate about 80. The average, the mean value for heart rate was 75, so it means that at least 20% had a heart rate over 80. So in these terms, they were presented with sympathetic overdrive. How they responded to the addition of bisoprolol, when you look at the major results and primary endpoint was the difference compared to placebo. As you can see here, after 4 weeks during the second visit, there was a significant reduction of both systolic, diastolic blood pressure as well as a heart rate. But when you look all together at the number of patients who were controlled on this combination treatment, bisoprolol along with amlodipine offered a blood pressure control in almost 3/4 of the subjects, both in terms of systolic and diastolic. So you have a very simple measure, a tool which is very effective, one pill that allows you to control blood pressure of subjects who are not controlled on monotherapy, and you can achieve this in more than 75% of subjects. So again, when we talked about combination of bisoprolol and amlodipine, I think that more attention should be offered to this beta blocker part. Because there's a lot of misunderstanding about the efficacy and also a clinical use of beta blockers, in particular in treatment of hypertension. You are all aware that in 2018, European guidelines following English recommendations removed beta blockers from the major line of treatment. However, beta blockers are still considered, as I showed you a quote from European guidelines, are still considered a major drugs, a major class of blood pressure lowering medications. However, not all of the guidelines removed beta blockers from the first line. You have an example here of Korean and Canadian guidelines from the same period of time, 2018. Also recently, you may easily find an expert opinion which contradicts what is stated in guidelines. What is of interest when you look at the names of those people who are the authors of this expert opinion, you can find experts who also contributed to the last European guidelines, like my friends Guido Grassi or Giuseppe Mancia, and as well as Sverre Kjeldsen, who were among the authors of European guidelines for last several years. So what happened that they changed their mind? Fortunately, I didn't have to change my mind. I was always convinced that beta blockers should remain the first line of treatment. First of all, when you look at the data from randomized clinical trials, the trials which compared two different blood pressure lowering medications, and you look at the clinical outcomes that take into account the degree of blood reduction. So additionally, you calculate the effect by an actual reduction in blood pressure. So when you look at the data, you don't see any significant difference between different classes of blood pressure lowering medication. So they are equally effective when it comes to cardiovascular protection. This is a meta-analysis that included more than 900,000 patients. Also, when you look at very recent meta-analysis, this one comes from 2020, and you look at the studies particular with the use of beta blockers. I hope that it can be legible for you. But when you look here, for example, when you take only hypertension studies and compare beta blockers to controls, you see here that is a clear advantage or benefits on the side of beta blockers. And also, let me go back a couple of years ago and show you some data from pivotal milestone trials in medicine. Definitely one of those trials was UK PDS, not only because it made a metformin, major drug for diabetes, but also UK PDS was the first trial who was targeted on cardiovascular prevention in diabetic patients, not on the blood glucose control. And as you remember, in this trial, there was blood pressure reduction arm. They were two different trials. One was comparing intense and standard blood pressure reduction with no difference between two groups. Another was comparing treatment of blood pressure based on beta blocker on ACE inhibitor. There was also no difference between these two arms. However, UK PDS has ended in the 1990s, and those patients were then observed by their family physicians, and we can watch the clinical outcomes. And as you can see here, after 20 years, when UK PDS trial was ended, those who were initially randomized to the beta blocker arm had significantly lower mortality. So beta blockers do work, and they can offer a cardiovascular protection, maybe even better than other classes of blood pressure lowering medications. Experts nowadays point into situation that if you have patient with hypertension, it's quite exceptional that you have a patient with hypertension only, with high blood pressure only. It happens only in the young adults at the very initial stage of hypertension. Usually we have patients with long-term history of hypertension, complications, and concomitant clinical conditions. And when you look at the list of different diseases where beta blockers can be beneficial, you can easily name almost 50 different clinical situations where beta blockers can offer additional benefit. It refers not only to well-known situations like heart failure, people after myocardial infarction, or women with childbearing potential. But also you have a long list of other cardiovascular diseases where beta blockers have a compelling indication. Also, you see diseases which are not related to the heart and peripheral circulation, but you use beta blockers, for example, in subjects with hyperthyroidism to control the symptoms of thyroid toxication. So in other terms, if you have a patient with high blood pressure, usually in majority of them, you will find additional indication to prescribe a beta blocker. Also, nice guidelines. The first one that removed beta blockers from the first line of treatment noted that in particular situations, beta blockers should be prescribed, and it refers to young women who want to have a child, or people who cannot tolerate RAS inhibitors, but also to those with an evidence of increased sympathetic drive. And increased sympathetic drive is very common in hypertension. Almost half of them have symptoms of elevated adrenergic activity. And this translates into different effects. Usually when you talk about increased sympathetic overdrive, you think about myocardial contractility, oxygen use by myocardial cells, heart rate, but it's not only. Our adrenergic system controls vascular tone, controls sodium reabsorption, and as I mentioned to you a moment ago, renin release. So activation of sympathetic centers in the brain affects many mechanisms that contribute to hypertension, and you can easily identify them in more than 50% of subjects with hypertension. In particular, it's quite common in those with the initial stage of high blood pressure, in obese subjects, smokers, patients with chronic kidney disease, and sleep apnea. And therefore, one may ask, okay, how can I identify a patient with the sympathetic overdraft? In our department, we do microneurography. It's a very sophisticated procedure. You put a very tiny electrode into a sympathetic nerve that runs along the peroneal nerve on the calf. Okay? So it requires a lot of skills and equipment. But as you can see here, activity measured directly by microneurography correlates very strictly with the basal heart rate. And this does occur in many groups of subjects, either healthy controls, but also in people with hypertension, obese, or subjects with heart failure. Heart failure is another example of very high efficacy of beta blockers which reduce mortality in subjects with heart failure. And we did a study using SPRINT database. You know that SPRINT was a trial that included subjects with high risk and high cardiovascular risk and hypertension. They were treated to two different systolic blood pressure goals, below 140 and below 120. Those on intense control of blood pressure did much better. Therefore, trial was prematurely interrupted. We have the SPRINT database, and we did a couple of analyses. All of them have been published, so you can easily access them using PubMed database. So, for example, we looked at the basal heart rate and cardiovascular complications. Then when you look at the people without history of cardiovascular disease, blue line, as a clear-cut relationship between basal heart rate and cardiovascular complications like MI, heart failure, or cardiovascular death. But when you look at those with the history of cardiovascular disease, there's no such a correlation. And we are at this moment analyzing the data to find an explanation. Probably this correlation is neutralized by the use of beta blockers. So it's sort of a suggestion that they are really protective in subjects with hypertension. Also, sleep apnea is a clinical condition which is increasingly common, and sleep apnea is associated with sympathetic overdraft, not only during the night when subjects have the episodes of hypoxia or anoxia, but also during the day. When they are awake, also they have elevated adrenergic activity. So we checked the database that included 33,000 of subjects with sleep apnea all over Europe, and look at the control of blood pressure. And as you can see here, the most effective class of medications to lower blood pressure in subjects with sleep apnea, there are beta blockers. So theoretically, the medication that controls sympathetic overdrive should be the most effective. And this is the case. Also, obesity is a state with sympathetic overdrive. Therefore, one may assume that if you have an obese subject with hypertension, he or she should respond better to treatment with beta blockers as compared to lean individual. And that's true. And here you see the data. Black columns are the lean subject, white columns are obese subject. They all were given the same dose of beta blocker, but as you can see here, reduction in blood pressure was much greater in obese subjects. It also can be seen in terms of reduction of heart rate. Also, when we talk about different classes of blood pressure lowering medication, there is an issue of ethnic background. And there's a common notion that, for example, blacks respond better to diuretics and calcium channel antagonists. However, when you look at different clinical trials, there is basically only one trial that included only people of Afro-American origin. I'm talking about ASK trial that was completed 20 years ago, and it looked at the most effective way to prevent a development of chronic kidney disease. And there were 3 drugs in this treatment regimen given separately: amlodipine, metoprolol, and ramipril. And when it comes to nephroprotection, all of them were equal when it was measured by reduction in GFR. But we don't have any other trials that compare different combinations in blacks in terms of clinical outcomes. You can look only at the degree of blood pressure reduction, but there's a certain objection, because when you compare blacks with other peoples in these trials, in majority of these trials, black people had a higher initial blood pressure. Therefore, one can expect that when you give the same drug, the same dose, you will have still higher blood pressure in those subjects. And when you look at, this is the quote from one of the review papers on ethnic background and efficacy of blood pressure lowering medications, when you look at the effect of race, you can see that within the same ethnic group, you have the same variability and response to different blood pressure medication. So it's not the race which is the most important factor in prediction of blood pressure lowering effect. Let me go back to the SPRINT trial again, and you remember that this intense treatment was much better as compared to standard blood pressure control. Please note that there was a population of blacks. It was almost 1/4 of patients who were recruited to this trial. They were equally represented in intense and standard treatment arm. But as you can see here, in the standard treatment arm, the use of beta blockers was significantly lower and was associated with a higher risk of significant cardiovascular complications. So again, I would like to summarize that definitely there are many reasons that beta blockers should remain the first choice drugs for treatment of hypertension. I think that the major argument is that the clinical effects are directly related to blood pressure reduction itself, and beta blockers are equally potent as other classes of blood pressure lowering medication. And also, when you use modern beta blockers with high cardio selectivity, with high affinity for beta-1 receptors, the potential side effects that you are afraid of is relatively low or even minimal and can be neglected. Also, let me draw your attention to the fact that when you look at the other classes of blood pressure medication, because when you look at the guideline, they say, well, you have to start treatment with RAS inhibitor, because we have data from randomized clinical trials that RAS inhibitors protect against different morbidities and mortality. However, all these trials were done against placebo. For example, HOPE trial, the first trial, which put an ACE inhibitor on the first position in terms of cardiovascular protection, was against placebo. Okay? And the authors of this trial were writing that you cannot explain the difference in cardiovascular risk based on the difference in blood pressure itself, because the difference was minimal, 5/2 millimeters of mercury. However, in the HOPE trial, blood pressure was not measured on a regular basis. And there's a subgroup of patients who had 24-hour blood pressure monitoring. And when you look at the data of these patients, you see that there's a tremendous difference between ramipril and placebo when it comes to blood pressure reduction. And this can easily explain all benefits which were observed in the active treatment arm. Also, we have another trial that hailed the role of ACE inhibitor, which was an Europa trial, Europa study in patients with stable coronary disease. Now we would say a chronic coronary syndrome. They were treated with either ACE inhibitor or placebo, and there was a difference in mostly in the number of hospitalization for heart failure. And we know that ACE inhibitors are used for treatment of heart failure. You cannot exclude that it was something which we call preemptive treatment. And first of all, in the protocol, there was a run-in phase that excluded patients who were intolerant to ACE inhibitor, something which we don't do in our clinical practice. You offer a drug, then you look at these symptoms of intolerance. But what is important, when you look at concomitant medications, the benefits in patients with coronary heart disease were observed only in the group who was treated with beta blockers. So the combination with beta blockers was essential to observe a clinical benefits. And another study, the study that made an experts to change their mind and put the beta blockers in the second line of treatment of hypertension, was an ASCOT trial. ASCOT trial included subjects with hypertension, high cardiovascular risk, who were divided into two treatment arms. One started with amlodipine, with perindopril added to control blood pressure. Another one started with atenolol, and thiazide diuretic was added. The trial was stopped because there was a reduction in mortality in this amlodipine treatment arm. However, when you construct a protocol for clinical trial, you select the primary endpoint and the entire design, the number of patients, period of observation, all statistical calculations are based on the primary endpoint. But when you look at the primary endpoint, there was no difference. There was no significant difference between atenolol and amlodipine along with perindopril. So in my opinion, it's still not enough to delete beta blockers from the first line of treatment. However, in this trial, as well as in 80% of all trials in hypertension, atenolol was used as a beta blocker. Atenolol given once daily, frequently in a single fixed dose. Atenolol is not a drug that allows you to control blood pressure for a long time. You see here a comparison of bisoprolol and atenolol based on 24-hour blood pressure monitoring. And you see a tremendous difference. So in other terms, people who were treated with atenolol were not offered a maximal protection related to blood pressure reduction. Also, when you look at different trials comparing different classes of drugs, they may be a surprise for you. But the major benefit comes to a reduction of blood pressure. So even if you take diabetic patients and look at the cardiovascular endpoints or chronic renal disease, there's no difference between different classes, RAS blockers and beta blockers included, if you achieve the same level of blood pressure. This is another example. First trials with ARBs and ACEs in people with chronic kidney disease were performed against placebo. Okay? And you can see here, and even if you get a placebo or other drugs, but you have the same level of blood pressure reduction, there's no benefit in terms of nephro protection. So once again, let me come to the point that beta blockers are highly effective, that combination with amlodipine offers another advantage, that data from clinical trials does not allow to delete beta blockers from the first line of treatment. They are still have a very strong position and place for our patients with hypertension, and therefore, I would like to present my own conclusions. What are the target groups for the combination of bisoprolol and amlodipine? Definitely those with sympathetic overdrive should have beta blocker bisoprolol in their treatment regimen. Also, those who have other indications for beta blockers, like coronary heart disease, post-MI, and so on. You have seen the list of more than 50 different clinical conditions. Also, patients who cannot be controlled and don't tolerate other drugs. And also, this is a classical indications from SMPC that those who are on separate pills, you should switch them to FDC because this will improve compliance and better blood pressure control. Thank you very much. And of course, I'm waiting for questions during Q&A session. Concern? Okay, now. Yeah. Then advantage still patients compliance and that. Okay. Okay. Let's look at the third question, third one. The answers, the third question was about, still okay. You remember sleep apnea? Yeah, but still, yeah. Okay. Okay, so you haven't changed your mind very drastically. Still, you are very constant with your opinion in terms of indications. If we have a time during a Q&A session, I will address this issue with mood disorders and depression, because there are data that come from specific clinical trials performed in the randomized controlled manner.
Good. So
we may have a very solid evidence. What is the risk for all these complications?
yeah.
Okay, so we will. Okay, so basically, what did me, my old self, learn from here? I must admit, I know in Nigeria we used to be all skeptical about using beta blockers for high blood pressure, but as more data comes about, we can see there's a significant role for beta blockers in high blood pressure. In my own practice, I notice it as well. There's several, especially young people, people with sleep apnea. So as Prof has said, there about 50% of patients with high blood pressure have a significant sympathetic overdrive. And most patients will require more than one drug, most, at least in my practice. Usually by the time I get to see a patient, they've already come with 3 drugs. And we have to start trying to figure out what else to do. There was a question I want us to remember. He put up the slide about divisibility of the fixed dose combination. You know, if you can split it in two and go with half the dose, you know, that's important for us in this part of the world. That time his mic wasn't working too well, so I'm not sure what he said. So we'll ask him again later on. And as we know, compliance with fixed drug combination is much better. So we will leave it at this. We're going to ask some questions later on about beta blockers in blacks. He touched on it, but we need to go more into it because we need to see the real evidence for beta blockers in blacks. And his last slide pretty much summarized everything. The target groups for this fixed dose combination of bisoprolol and amlodipine would be those with sympathetic overdrive, those with coronary artery disease, and those who cannot tolerate ACE or ARBs. So with that, we wrap up Prof's presentation and we'll go to the next speaker, who, even though we are friends, we've been friends for a long time, you know, I don't know all her titles. So I had to ask her, I said, Prof, what are your titles? But I'd like to introduce Prof. Amam Mbakwe. I think most of us know her here. She's currently Director of Medical Education and Development. She's Vice President of PASCAL. I don't know if you all know what PASCAL is, but it's the Pan-African Society of Cardiology. She's the Vice President, West African region. She's also, I'll just say this last one, recently elected Vice President-elect of the World Heart Federation, correct? Yes. So, you know, that's a big deal for us over here. So we're very proud. Please, Prof, can you come up? Thank you. So she's going to give us a real-life patient.
Thank you, Dr. Yemi. My own title is very simple, but I think Prof had given us a good lecture with why we should use beta blockers. But I think we've been sitting for a while. Can we please stand, stretch our legs a little bit so that we don't move from hypertension to DVT and something else? Just stretch your legs a little bit and then sit down again. Okay, so you can please sit down. You can please sit down and then we can start. Okay, so mine is very simple. Case presentation. We're all managing hypertension. Looking through the room, I can see nephrologists, can see cardiologists, can see hypertension specialists, primary care physicians, and pharmacists here. So I've been introduced. So this, let me stand over here. So I'm presenting Mr. MW, who is an IT, a 50-year-old IT specialist, you know, works extended hours, we know how it is, but he exercises regularly. He has no special habits of medical importance, no family history of importance, but he presented with increasing shortness. Please don't change for me, I'll change at my own rate. He presented with increasing shortness of breath and palpitations. Please note the presentation. Blood pressure presentation was 160 over 107 millimeters of mercury in both upper limbs. Heart rate was 113. BMI 25, not too bad. Apical heart sounds, there was an S4 at the apex, but the chest was clear. So, what investigations would you order? This looks like some of the patients that show up in our clinics. Please vote now, scan and vote. Okay, so that's quite good. About 80% will do an ECG, will do a chest X-ray. Nobody will do a chest X-ray. Echocardiogram, 11%, laboratory, all the other laboratory tests, 3%, but majority of people will do all of the above. Okay, can we take off the poll? So this is from the ESC guidelines about the routine laboratory tests, you know, that you would order for a patient who shows up in your clinic in evaluation. So there's a hematocrit, fasting blood sugar, and glycated hemoglobin, blood lipids, electrolytes, uric acid, creatinine, liver function test, urinalysis, 12-lead ECG. So most of that we had said we will do. The guideline also asks us to screen for hypertension-mediated organ damage. And if you're doing that, your 12-lead ECG, because you're looking for left ventricular hypertrophy, you're looking for atrial enlargement, you're looking for axis deviation, you're looking for T-wave abnormalities, the urine albumin-creatinine ratio, looking at the renal function, fundoscopy, looking at the eyes and what is happening in those areas. Okay, so if you're looking for more advanced hypertension-mediated organ damage, then we can escalate the investigations we're doing. Then echocardiography will come in. Of course, we know that echo is more sensitive and more specific if you're looking for left ventricular hypertrophy. Carotid ultrasound if you're looking for plaques, abdominal ultrasound and Doppler studies, then pulse wave velocity, ankle brachial index, cognitive function test, and brain imaging. But all these will depend on your clinical evaluation, because not every patient is going to go through, this gamut of tests. So yes, we're investigating the patient, but the starting point is proper clinical evaluation, which will direct us as to what to do next. Okay, so this is the ECG, with the MW that we are discussing. So the major thing we can find there is a sinus tachycardia. The rate is about 100 per minute. It's just X-ray, a bit of an unfolding, but not very remarkable. And this is his echo. His echo looks normal, the left ventricular size and the left atrial size. So these are the results of an investigation. Creatinine 1, liver function normal, TSH normal, sodium 138, potassium normal, the lipid profile not bad, HbA1c 5.12, urinalysis was also normal. So there's really not much going on in this area. So at this point, which other investigation would you order? Would you order a coronary CT? Would you do serum catecholamines, plasma aldosterone levels, or renal artery Doppler? Please vote now. These are decisions we take every day, Dr. J. Which one you need to see? Okay. Okay, good. Oh, some people are changing. Some people are changing their minds. Yes, I agree with the serum catecholamines. Okay, because we know, the major thing, the man has hypertension, but that's heart rate. And we know that it could even be pheochromocytoma. We know that not all pheochromocytoma will present with episodic hypertension. Some of them would have persistent, elevated blood pressure, but we know that the palpitations and all the other things will be part of it, and all the other autonomic dysfunction that, people are changing their mind. Why would you do a coronary CT? Why would you do a coronary angio? You want Dr. Yami to make more money in Lagos. So why would you do a CT, really? Okay, at this point, I don't think that would be, the point to where we should be going. But I agree with majority of the people in that the next step would be serum catecholamines. Okay, so what do you think? Is this man high risk? Is he low risk? Is it a moderate risk, or is it very high risk? Because we're seeing these patients every day, we're evaluating them, we're taking decisions based on their risk category, the risk profile. Please vote now. You think he's very high risk, he's low risk? Okay, so we are. Okay, people are still changing their minds. Is it possible to have a split screen so we can see how the virtual people are voting? You did it before. Okay, so some people think okay. So the virtual people, most of them think he's high risk, but in the hall, the other time we had a split screen where we had the results of people who are physical and those who are virtual. Exactly, thank you. So, so maybe there's an advantage of being present in the hall. Because the next slide we should. So can we take this off and see what ESC tells us? Okay. So this is the ESC, guideline from the ESC guideline categorizing patients. Why I like this chart is that it just tells us that the numbers don't answer all the questions. Somebody who has, a lowish blood pressure may be at a higher risk than somebody who has a much higher blood pressure. For instance, this person with 140 over 150, 140 over 90 may actually be moderate to high risk compared to this other person who has, a higher blood pressure. But a lot of us tend to be number centric, and we're all concerned about the numbers and not all the other things. But now we have to add all the other things that are coming in. What else is this man bringing onto the table? What are the risk factors he's bringing in? Our patient has 2 risk factors. One is what? Okay, don't worry, I don't have a question. So you're right, the patient is moderate to high risk, okay, because his blood pressure was 160 over 110, right? And he has a tachycardia of 113. So 1 or 2 risk factors plus that blood pressure puts him in that moderate, moderate to high risk group. So this also tells us that the numbers don't just answer all the questions, and for us to look after the patients properly, we need to bring in all these other things into consideration. So now you decide to treat Mr. MW. What would be your strategy? Lifestyle changes alone. This one is a giveaway. Immediate medical therapy in addition to lifestyle. Okay, so please just vote so that we can have dinner. Merck might decide not to give us dinner if you don't vote. Oh, sure. Okay, so immediate medical therapy in addition to lifestyle modification. Can we take out the result of the polls, please? Okay, so this is from the ESC guidelines, and our patient is in this grade 2, 160, 110. So lifestyle advised, immediate drug treatment for all patients in that group. Okay, so for the lifestyle modification, we still remember the weight loss, the DASH diet pattern, the reduction in dietary salt, and also, increased potassium intake in fruits and vegetables and all that. But also remember that the benefit you get is actually more for hypertensive patients than for normotensive, because if you look at the 2 columns towards at the end of that chart or table, okay, so while weight loss is giving you -5 millimeters of mercury reduction in blood pressure for the hypertensive, the normotensive is about -2 to -3 and all the way down. And then if you look at the recommendations from the ESC, salt restriction is the class 1A indication. Alcohol reduction. There's a lot of debate about alcohol. So when they say alcohol reduction, but WHO has said there is no safe level of alcohol. So if the patient is not taking alcohol, please let him not start. If he can stop, let him stop. But if he can't stop, let us reduce it, because some people will hear all sorts of stories. A little bit of alcohol is good for your heart. And they tell me they're taking red wine and they'll drink a bottle of red wine, every day. But WHO says no safe level of alcohol. So increased consumption of vegetables and fruits and all that, unsaturated fatty acids, class 1A recommendation, body weight control 1A recommendation, regular exercise 1A recommendation, cessation of smoking 1B recommendation. Okay, so according to the ESC guidelines, what is the threshold for blood pressure treatment? I think some people like the ACC/AHA guideline here, because I said ESC guidelines. That's how exam goes. You may be right, but I said ESC, and ESC is quite specific. So 140/90, greater than 140/90 is the threshold for treatment. Can we take up the polls now? Okay, so this is the ESC treatment threshold. So more than 140 millimeters systolic and more than 90 millimeters mercury diastolic. And if you remember a few years ago, this had caused a lot of problem when GNC 8 came up and was trying to push the threshold upwards. And for once, I was very proud to be a Nigerian, because one of Nigerians in America who wrote the minority report, not agreeing with all the new thresholds, because we know that the consequences of hypertension is worse in the Black population. So why push up the threshold? Is it so that we use the emergency room more, or what? So nobody knows what it is, but that's politics of medicine. So this is another one. So ESC, ESH guideline, what is the target for blood pressure treatments? Is it 130 to 139 over 80 to 89? 130 to 139, 70 to 79, 120 to 129, 80 to 89, or 120 to 129, 70 to 79. It's distributed around the whole place. Okay, so in here, majority of the people think is 120 to 129, 80 to 89. And the online participants, it's like evenly distributed. Some think it's 130 to 80, over 80, 89, and 120 to 129, 70 to 79. But that is not exactly what the ESC says, what the guideline says. Can we take out the polls, please? Okay, so this is the ESC guideline targeting blood pressure reduction. So for hypertension alone, not hypertension plus, because we have hypertension alone, hypertension plus diabetes, hypertension plus CKD, hypertension plus coronary artery disease, and hypertension plus stroke and TIA. So our patient is in the first column. So it says target to 130, not less than 120. So that should be 120 to 129. And then diastolic 70 to 79. So now we've come to the meat of the matter. So what medications would you start with? 1, 2, 3, more than 3. After Professor Garcia's lecture, if anyone misses this one, we'll withdraw your registration tag. Enema for the breakfast you have eaten, and we send you home. Okay, let's see how we're voting, okay? Okay, so at least, Mr. Charles, we listened to Professor Garcia's lecture. Okay, so everybody, most people think we should use 2 medications, which is also what the guideline says. Please take off the, okay, so the ESC says it is recommended to initiate an antihypertensive treatment with 2 drug combination, preferably in a single pill, preferably in a single pill. Exceptions are frail older patients and those at low risk and with grade 1 hypertension, particularly if systolic blood pressure is less than 150 millimeters of mercury. But we also know that even if you start with a single pill, some years down the line, a single tablet or molecule, some years down the line, these patients will require another molecule to control their blood pressure. So what would you choose? ACE inhibitor plus CCB, ARB plus CCB, Amlodipine plus a diuretic. Why are you laughing? RAS and diuretics, beta blockers, and CCBs. Interesting. Can we have the results of the polls? Oh, some people are changing their minds. Okay, so the online community will do, all of them will do beta blockers and CCBs for obvious reasons, but we have a few here who will do amlodipine and diuretics and ACE inhibitors plus CCBs. So let's just go through some of those combinations, to see what happens, because no matter what you choose, there'll be issues. Okay, so we're all weighing the benefits and the risks and choosing where benefits outweighs the risk that you think may happen. So if you decide to use an ACE inhibitor plus a CCB, so that, for example, ramipril and felodipine, of course, you may control the blood pressure to 130/80, but remember that patient may also have the irritative cough, okay, which would affect compliance or adherence, and because of the quality of life issue and the sleep quality that will be affected. And of course, we don't expect to achieve heart rate control. And from all we've heard, this afternoon or this evening, heart rate control is important in the management of this patient. Remember, we're not just looking at the numbers, we're looking at the CV outcomes after we've looked after this patients. Okay, so you decide to use valsartan and amlodipine, that's an ARB, and amlodipine. Of course, blood pressure may be controlled, palpitations will persist, may even get worse, and heart rate control is not guaranteed, most likely more than 94 beats per minute. I remember that safe limit is said to be less than 80 beats per minute. So some people chose amlodipine and diuretics. So amlodipine and indapamide, of course, we expect to get a good blood pressure control. But remember now that we're looking at this patient holistically. We're not just looking at the numbers. It's not just the blood pressure that we want to control. So the blood pressure may be controlled, but think of the frequency of micturition. A lot of patients have frequency even with the calcium channel blocker alone, and with an added diuretic. So that would happen. But the palpitation will persist, and the heart rate control we won't get with this combination. So if you decide to do ARB plus hydrochlorothiazide, of course we expect blood pressure control, but that palpitation and the heart rate, the tachycardia, will persist in this patient. Okay, so bisoprolol and amlodipine that you have chosen, we expect to get a good blood pressure control. The heart rate will be controlled. And of course, like we've been shown, especially bisoprolol is neutral on the metabolic profile. So this will be the thing to choose. But I'm not employed by Merck, and I'm not on their payroll. So my own point is proper evaluation of the patient, proper profiling, and then you can decide what best works for each patient that you're looking after. So, and this is from the ESC guidelines that says it is recommended that beta blockers are combined with any of the other major drug classes when there are specific clinical situations, for example, angina, post-myocardial infarction, heart failure, or you need heart rate control. And heart rate has been added as a risk factors, that affect cardiovascular outcomes. So it's not just when you're looking at the, risk profile of the patient. I talked a lot about evaluating the patient. So when you're doing the demographics, whether it's gender, whether it's a man, of course, it's a man's world, so they can enjoy the benefits of hypertension. So age, smoking, total cholesterol, all that, and you find heart rates more than 80 also contributes to the outcome, for these patients. And this is from the Framingham study, okay, looking at the effects of heart rate on mortality in hypertensives. And these are the groups: heart rates less than 65, 65 to 74, 75 to 84, and 85 plus, okay? And what you find is that whether you're looking at coronary heart disease, you're looking at CVD, or you're looking at all-cause, mortality, the event rates go up as the heart rates go up. So nobody is exempted. You're looking at coronary heart disease, mortality from coronary heart disease or general CVD or all-cause mortality, it goes up as the heart rate goes up. So we need to control. And then looking at this study, using a hazard heart rate less than 60 beats per minute as a reference group for one, you find that 60, if you look at 60 and 80 and more than 100, the relative risk goes up. You have 1.5 for above 60, It goes up to 278 once you hit 80 beats per minute. And by the time you hit 100, it's 3.31. So the heart rate is important in the management of this patient if we're looking at outcomes and not just the numbers we're trying to control. So what's the relationship within resting heart rates in hypertensive? Okay, so in hypertensive men, there's a positive association between the heart rate and all-cause mortality, and hazard ratios from 1.9 to 2, to 2. And also, if you look at CV mortality, and this association is actually stronger in hypertensives than in normotensives. So that your hypertensive with a very high heart rate is at a higher risk than the patient who has higher risk than the patient who has who doesn't have a high heart rate. And it's also been found to be a better predictor of coronary artery disease in those patients. So different pathological, mechanisms, the relationship between resting heart rates and CVDs. So it enhances the atherosclerosis and vascular stiffness, myocardial ischemia, encourages the ventricular arrhythmias, left ventricular dysfunction, and heart failure. And these are there's the pathway. So elevated heart rate will lead to vascular damage, which will lead to atherosclerosis. And if there's an existent atherosclerosis already, it actually causes a progression or a worsening. And of course, with a high heart rate, there's increased demand, increased oxygen demand, increased myocardial work, and decreased supply. And then this could also lead to plaque rupture. And of course, the increased oxygen demand will lead to ischemia in the short term. And of course, in the long term, we can have major CV events. So the heart rate is not as innocuous as we have all assumed in the past. So why choose bisoprolol? Like we said, is neutral on the lipid. So this study had looked at, the lipid profile of patients, the starting point, 1 year, 2 years, 3 years, and up to 5 years. And if you can see the lines, kind of flat all through. So whether you're looking at total cholesterol, you're looking at the triglycerides, you're looking at HDL cholesterol, or you're looking at LDL cholesterol. And of course, the effect on sexual function, which is, which we all know, we all run away from, when we discuss beta blockers, okay? It's quite minimal with bisoprolol because it's highly beta selective. And please, sexual function, we shouldn't dismiss it. It's an issue. And I think as we evaluate these patients, we should open the door for this discussion to happen, especially when it's a male patient seeing a female doctor. Because for the African man, for the Nigerian man, his sexuality is important to him. And remember that the hypertension you're worried about is not giving him any symptoms, it's not giving him any issues. You are the one that brought your speak and decided that he's hypertensive. So as far as he's concerned, he didn't have any issues until you came with your medications. So please, let's not play around with those things. And we're talking about quality of life. It's not you, it's about the patient. What makes his life, quality? What gives him quality of life? Because a lot of times we've taken on roles as physicians, we think for ourselves, we think for patients, and we're wondering why we're not winning the battle. So bisoprolol has, the highest beta-1 selectivity compared to metoprolol, atenolol, carvedilol, or propranolol. Okay, so which means the more effect on the beta-1 than the beta-2 receptor. So all the other things you're worried about with the beta blockers, the effects are much reduced when you're using bisoprolol. Of course, amlodipine, we all know, we have has a track record being used in trial. Prevents, Ascot, DPLA, CAFE, all hearts. And nobody needs to preach to anybody about the effect of amlodipine and of course the long, duration of action that makes it easy for a patient to, adhere to treatment. So combining both of them, what are we getting? Complementary mode of action for optimal BP control. Inhibits the body's counter-regulatory response when using only one antihypertensive agent. More effective in moderate and severe hypertension. Okay, so we know that 10 to 15% of hypertensive population are at high risk and decreases BP variability more than a single agent, and that would lead to stroke. Professor Gathian showed this slide earlier on. Okay, this is a real-world study looking at adherence, patient adherence with a single fixed dose combination of bisoprolol and amlodipine. And what you find is that if you look at excellent, those whose adherence were judged as excellent, and those whose were judged as good. Okay, so if you add both of them, the good and the excellent, you had about 99% of the patients adhering to medication, which is not what we get in most of our studies. And then for phase 3 trials, you may get this because you're following the patients up, you're calling them, you're making sure they're taking the medication. But for real life or real world studies where the patients are free to do what they like, to get this kind of adherence, it's all order. And of course, there was also blood pressure control, not just adherence. If you look at this, I hope I'm not blocking so looking at the systolic blood pressure and the diastolic blood pressure, the pulse pressure and the heart rate starts 6 months after treatment. We can see the good control and the good numbers that happened with that combination. So the benefits of adherence and persistence, patients in that study after 6 months had excellent, about 85.6% had excellent adherence in association with improvement in blood pressure control. So you're getting, the double benefit from using the medication. So the benefits of bisoprolol amlodipine combination, any case of hypertension, especially with a heart rate of more than 80 beats per minute, we know that it effectively controls sympathetic overdrive, especially in stage 2 middle-aged hypertension. Contains the therapeutic doses of bisoprolol, 5-10 milligrams, but we need to find out if Merck has brought 10-10 because it just talks about the 5-5 and 10, 5-5 and 5-10. So we need to know if there's also 10-10 because some patients may be in that arena. Can be given at any level of EGFR, can be given regardless of the liver function, and is also metabolically neutral. So as I conclude, hypertension is the most prevalent risk factor for cardiovascular disease. We should assess our patients thoroughly. Please, that is where we start. It's not about whether Merck is asking us to do bisoprolol and amlodipine. You're going to get the most benefits if that patient is properly evaluated so that the best patient will get the right drug for the right benefits and right effects. So choosing the correct class of medications is of utmost importance for the sake of both efficacy and safety. Not all beta blockers are the same. Not all twins are born equal, as they differ in potency to control heart rates and incidence of side effects. Bisoprolol amlodipine, complementary mode of action for optimal blood pressure control. Thank you for listening to me.
That was a very nice presentation. And I think, please, could you go back to her first slide? I needed some clarification. We have to go back manually. I'll wait. But, oh, okay. When you had it up, it was enlarged. So we didn't see the Mr. I saw MW. So I said, is this new classification now, man, woman? It's okay, so it's Mr. MW. All right, okay, thank you. All right, I think we all enjoyed that talk. And the most important thing I've learned is in this fixed dose combination is compliance. And that's what we all know. Compliance in fixed dose combination is very high. And the other very important thing Prof said, that you people I saw some women laughing. It's a big deal for men. ED, it is a big deal. If you don't ask, they won't tell you, and they just won't take it. Next thing, they're back with a stroke. So I always, and it's important. There's 1,000 different combinations, and this is this is one of the better ones as far as ED is concerned, and which is why 50% of our male patients don't take their drugs. That's a real big deal. So after this, we're going to a video presentation, correct? Then after that, we will have some questions and answers. And I think that one will be quite interesting. I have a few questions myself.
Multiple systems contribute to elevated cardiovascular risk, including vascular contractility, sympathetic nervous system, and renin-angiotensin-aldosterone system. Elevated blood pressure is associated with increased risk of cardiovascular diseases and mortality, and failing to achieve blood pressure targets is considered a major missed opportunity for cardiovascular disease prevention. An elevated heart rate is another important predictor of mortality. Patients with hypertension often require multiple therapies targeting different underlying mechanisms to achieve blood pressure control. For example, a beta blocker plus calcium channel blocker. The 2018 European Society of Cardiology, European Society of Hypertension guidelines consider beta blockers and calcium channel blockers to be the preferred components of a drug treatment strategy for patients with hypertension and concomitant angina. Why bisoprolol? Bisoprolol shows a dose-dependent blood pressure reduction over 24 hours. Bisoprolol leads to a strong blood pressure lowering response by blocking sympathetic adrenal activity and by reducing plasma renin activity. Bisoprolol is a beta blocker with a remarkably high cardioselectivity, which is associated with heart protection and for avoiding beta-2 mediated adverse events. Why amlodipine? The calcium channel blocker amlodipine markedly reduces peripheral vascular resistance, leading to an effective reduction in blood pressure. Several pivotal clinical studies support its choice as a first-line agent. Amlodipine has shown beneficial effects on cardiovascular and stroke outcomes in hypertension trials. Introducing Concor AM, a fixed-dose combination that adds up. A combination of bisoprolol and amlodipine targets three major systems: sympathetic nervous system, renin-angiotensin-aldosterone system, and arterial blood vessels for effective blood pressure reduction. Bisoprolol and amlodipine are clearly better together, as benefits of the combination are rapidly evident when compared to either agent alone. A switch from the free drug combination treatment with amlodipine and bisoprolol to the fixed-dose combination of Concor AM may lead to reduction in heart rate and long-term improvements in blood pressure control. In comparison to free drug combination treatment, the improved outcomes with fixed-dose combination treatment in hypertensive patients are probably due to good adherence and persistence. Due to better adherence, fixed-dose combinations are more likely to normalize blood pressure than free drug combination treatment. Real-world evidence data suggests that a systolic blood pressure and diastolic blood pressure normalization may be easier to achieve by using fixed-dose combinations compared to free combinations. In a large non-interventional study, Concor AM showed good to excellent adherence in 98% of the patients, leading to better blood pressure control in comparison to free drug combination. Concor AM helps to avoid the challenge of a multi-drug burden. In a large observational study, Concor AM offered enduring efficacy with a good tolerability profile and less than 1% incidence of adverse events. Concor AM is available in 4 fixed doses, giving you flexibility to match all potential doses of the 2 components in a free combination. Concor AM, where 1 + 1 = 3. The fixed dose combination that adds up.
So I think for the meantime, you can see the Q&A questions, the papers in front of you, and you can write the question. This is an option. Other option also, you can raise the hand, and then of course you can have a mic and go live with the question. Also for the live streaming audience, you can do the same, either writing on the chat the questions or even raising the hand so you can be promoted to panelist and go live with this. Yeah.
Okay, how many people have written down questions? Nobody? There's a piece of paper there. Can you hear me? There's a piece of paper on your tables to write down questions. Has anybody written down questions? Or you'd rather just come up to the microphone and speak? I you all asleep. I can't, no response one way or the other. Okay, can you hear me? Nobody's living here till you ask at least 20 questions or so. Just know all this quietness is not going to work. All right. Has anybody written down questions? Okay. Yeah.
Okay. I want to thank you. Okay, yeah. My name is Dr. Okechukwu, who's on my consultant cardiology from Eastwood Park Lane, Enugu State. I want to thank Meg for this program. I want to thank all the presenters for the excellent presentation. A few years ago, when Concor was first marketed to me by the rep, and he talked about his drug. So, excellent drug. I'll use it for my heart failure. You know, I'll use it for my heart failure. I didn't really see the place for something like bisoprolol in hypertension as a high up on the list for hypertension. So I'll use it for my heart failure. Very, very fine. No, they're marketing it as an antihypertensive. I couldn't really see his point. It was difficult to, and coupled with all the thing or ESC are, kind of step down beta blockers. They talk about the other things, RAS blockers and so on. And so, but today I'm glad to be in this presentation. Prof has done a very good job. I mean, all the profs. I mean, but the first speaker talked about some. He challenged some aspects of the ESC decision to step down beta blockers. So scientifically, not just their opinion. So I'm glad to hear that. And going further than that, to also say that most hypertensives anyway would require a beta blocker. If you think about it, obesity, diabetes, sleep apnea, almost no hypertensive is free of those conditions. So they end up using the medication, of course, including heart rate now. If you include heart rate, almost every hypertensive will use it. So I want to thank all the speakers and to say that going forward, I will not use Concor only for my heart failure. I'll use it for hypertension as well. Thank you.
Yeah, thank you. I think that's a good comment. Okay, I've got some questions. Okay. My spouse is a hypertensive patient, takes amlodipine and indapamide, 1.5 and 5 of amlodipine. Is there any concrete reason to change to Concor AM? Who wants to take that?
Okay, so we can't just from here tell you to change, but your spouse needs to be properly profiled. If the heart rate is not an issue, the blood pressure is well controlled, and there's no indication for using a beta blocker, it doesn't have any other things, that will indicate a sympathetic overdrive in the background, then, there's no need to change. But then if that blood pressure is not well controlled and some of these things are playing in the background, then we can have it as an add-on. Remember we said, if you remember the slide that was put on, almost everybody needed 2 drugs, but some people needed about 3. Some people actually needed about 4, to get to the proper blood pressure control. If you're going by the ESC guidelines that says 120 to 129 and 70 to 79 millimeters of mercury. Okay, so let your spouse be, you can ask whoever is looking after your spouse for a re-evaluation to see whether we need to add some other thing or the amlodipine and indapamide is doing the job that needs to be done.
Okay. Very eminent prof wants to ask a question, so I will personally take the mic to him.
Thanks. Yes, so good evening, everyone. I'm DK Oji. I work at University of Abuja Teaching Hospital. I want to thank Professor Gassion. Sorry if I've not pronounced your name very well. And our own Professor Mbakwe for what a wonderful time. And of course, Dr. Johnson. I will say that there is no doubt that bisoprolol beta blocker and amlodipine combination is very useful, especially in young hypertensive patients. Remember that Dr. Adibi, University College Hospital, Ibadan, did a work when he looked at sympathetic adrenaline and non-adrenaline levels in hypertensive patients, compared young hypertensive patient and also normotensive patient. Of course, we found that for hypertensive patients, the adrenaline level markedly elevated compared to non-hypertensive. So, of course, in our population, quite useful. Then I'm sure also in childbearing age, because it's much safer using it than using amlodipine and ACI or ARB because of the teratogenicity of ACIs and ARBs. Then my question is if you are pushed to the wall, or one of my questions, will you use amlodipine and bisoprolol in pregnancy? Will you use it in pregnancy? That is my first question. And then, yes, that's my first question. Then my second question is for Professor Gassion. You talked about beta blocker and a thiazide diuretic. Remember that that's a combination that most guidelines are not too happy with. They give you a lot of caution because of the metabolic effect. But it's like you are trying to defend that. So are you encouraging us, that is one of the choices we should consider in the treatment of high blood pressure? At what level does it come in the treatment of high blood pressure? So, for example, bisoprolol and hydrochlorothiazide. Thank you.
Now, okay. So when it comes to pregnancy, first of all, pregnancy, it's not a chronic disease. And if you have pregnancy-induced hypertension, usually it should resolve after 12 weeks. However, usually we start the treatment with systolic over 150, and in women with lower degree of systolic, when you had a history of cardiovascular complications, which in young females is not very frequent, okay? So the selection of drugs is based on safety data. So labetalol, I don't know whether it's available it is. So you are in a very good situation because in Europe, oral labetalol is really very hard to get, really. For example, it's not available in Poland, it's not available in Germany, it's available only in the Czech Republic. I have to send my patients to Czech Republic to fill prescriptions. So labetalol, if labetalol is not available, methyl-dopa is first choice usually. Then you have long-acting nifedipine, which is also hardly available, and usually we don't use amlodipine. However, it seems that amlodipine may be safe in people, in women, in pregnant women. Okay.
So, but the other thing, apart from the spectrum of pregnancy-related hypertension is a wide spectrum. So I can have a hypertensive going into pregnancy, already hypertensive. Okay, so like you said, I know that the ONG people don't like amlodipine. They prefer nifedipine, but bisoprolol, I don't think we have much data as, in pregnancy. So like you said, labetalol, but if I don't have labetalol, I'll do metoprolol, which we have a little more data on metoprolol, to control the blood pressure, but I wouldn't try bisoprolol and amlodipine for now.
Okay, next question. Can it be divided? I'll answer that one because I asked from the manufacturers. Yes, the pill can be divided, but only if it is too big to be swallowed by the same person. If you want to give it as a half dose, no, that is not advised. But if it's too big to swallow, then the same guy can take it, break it in two and swallow it. But the dosages cannot be guaranteed if you cut it in two. Okay, next question.
Sorry, Dr. Johnson, is that company whatever, or is it for real? You know, maybe we'll ask Professor Garcia. I asked this question because the time we had a Euperio, I actually asked the company whether we could split, and I got a dossier from Basel as to why I shouldn't split, why I shouldn't do this, and why I shouldn't do that. Until we had a meeting with an Asian country, and they said they were splitting because the doses were too heavy for their people, and it was working. And that, so I'm asking this question: is it for real, or is it sales policy?
Well, I can answer this one. Yeah, sure, because this is an important question regarding, I think you can hear me right with this point, right? Good. So for the case of the tablet, whether it's breakable or not, you will see that it's engraved. When you get the tablet and we looked at it, it's engraved. But the engraving is not for just equally divided. Like if I divide the 5, I will get 2.5 and 2.5. It's not the case. It's just engraved to break for the people who have difficulty to swallow. So it's not equally divided, cannot have equal dosages, only just for the case of easy swallowing, but not equally divided.
Okay, so that's sorted out. Now,
I have two questions. You passed to me two questions. Okay.
All right, that's the second part of your question.
There's a question about peripheral edema on subjects treated with bisoprolol amlodipine combination. It's a very good question because dihydropyridines are frequently accused of peripheral edema. And when it comes to adverse events, the frequency depends on the observational protocol. It depends whether you ask a specific question or you don't ask a question about edema and the patient reports edema by herself or himself. And gender is important because women pay a lot of attention to peripheral edema. Guys don't care about that. So when you look at the peripheral edema reported by patients, it's only a few percent, and it's quite unusual that you have to stop the drug. In our studies with Concor AM, the frequency of edema was really a single digit when it comes to actual numbers, not percentage. So it's not very high, and I think this is not a real clinical problem. Okay, and those also, if I can continue with a question about combination of beta blockers and thiazides, historically, this was the first combination ever, and this was bisoprolol with hydrothiazide, which was produced by Merck in the US under the trade name of Zayac, the first combination ever. And of course, it's not highly recommended nowadays because we are afraid of some metabolic adverse events. However, with cardioselective beta blocker like bisoprolol, which is metabolically neutral, in subjects, for example, who cannot be treated with RAS inhibitors, I wouldn't be afraid, I wouldn't be reluctant to prescribe this kind of combination. However, usually you have more neutral drug like Concor AM, bisoprolol plus amlodipine.
Okay. So I have a question here. Is there a reduction of ED from amlodipine with fixed dose combination of amlodipine and bisoprolol? You know, the story about ED in hypertension is actually hydra-headed. We know that hypertension on its own, with all the atherosclerosis going on, can lead to some erectile dysfunction. And of course, as men are getting older, you know, their sexual drive would also go down. So communication, my first point is to communicate with the patient, to have the proper communication. Amlodipine on its own actually causes ED. There are few drugs, antihypertensives, that would not give you ED, the ARBs. Okay, so amlodipine will cause ED. But what we're saying is that and beta blockers, of course, they are known. But if you're putting bisoprolol on top of amlodipine, then you don't expect that degree of ED, to happen. And then ED may not be a major issue, for non-adherence to that, to the treatment. But if a patient already has ED and that is a major red flag in the treatment, I'll veer more towards the ARBs, which have been shown to inadvertently improve, the sexual function.
Okay, thank you. All right, your turn.
Okay. I have three very good questions that I hope I can manage. Let me start. Is it necessary to adjust the dose of bisoprolol in chronic kidney disease patients, particularly for those on dialysis? No. Bisoprolol has a very constant metabolism. It's relatively resistant to, for example, the effect of genetic background, like different isoforms for CYP enzymes. You just check pulse, you check BP. There's no need for a particular adjustment. Next question, it's a very nice one. What happened to GNC8 guidelines, which said start with a diuretic before combination? It's a very good question. JNC, so Joint National Committee for Hypertension and so on, those were American guidelines. They are gone. JNC8 was published in, I don't remember, 2012 or something like that. And they were mostly affected by ALLHAT trial. Amam, you showed the, just briefly, ALLHAT trial. And in ALLHAT trial, hydrochlorothiazide, chlorthalidone was the number one drug. However, after the ALLHAT trial, there was a sprint trial which showed that it's more important to obtain the target blood level than to select a particular drug. Therefore, in all guidelines, you don't have an indication for any single class of blood pressure lowering medications like diuretics. Also, there was another argument behind chlorthalidone. Chlorthalidone in the US at that time, when you compare it to ACE or ARBs, was relatively cheap. So there was also a financial argument to prefer diuretics. Nowadays, we have mostly generics, so this money issue is not that important. And in the recent American ACC AHA guidelines, we have a similar recommendations for all these major classes. And the last question passed by Dr. Johnson to me, JNC, okay, the patient whose BP is normal with pulse rate below 90 beats per minute with persistent palpitation benefit from beta blocker only. Well, first of all, I would like in this case to, look for cause of this palpitation. Maybe she or he has an episode of atrial fibrillation. So I would request a Holter ECG to check for episodes of AFib. So maybe this patient may require anticoagulation treatment. Maybe we will go for, I don't know, ablation. It depends on the individual case. And if his blood pressure is normal, it means it's, I don't know what is the age of the patient. Well, let's say that she, because frequently women, they complain of palpitations. If she is, I will go for blood. I mean, normal, if it's below 130 over 80, probably you need 2 drugs to have this blood pressure levels. So beta blocker will not be enough, I'm afraid. So definitely I will leave the patient on beta blocker, but probably she or he would require another drug to be added, preferably in a combination. I don't know if that answers the question.
Thank you. So I have a question here that says, is there any side effects so one must check out for on this drug? I'm not sure. The point is that bisoprolol is a eureka. There's no side effect at all. But remember, we're looking at grades and degrees of side effects. Okay. I mean, every drug has its own side effect, but I'm using the drug, I'm looking at the benefits, I'm looking at the risk ratio. So all the issues we have with beta blockers, you know, we say that it's less with bisoprolol, the erectile dysfunction, the metabolic disturbance, you know, the fatigue and all that goes on, and the worsening of asthma for patients who have, you know, asthma is less with this drug. But we also need to evaluate the patient, because not every patient is the same. Somebody might take the bisoprolol and, you know, go to the other end. I remember that as I'm giving the bisoprolol, there's also a chance that I may push your rate so low that I may have to withdraw. So we're not saying bisoprolol is eureka. You know, you put it there and then go to bed. You know, so proper evaluation and also follow up and looking out for those things. But that the side effects with bisoprolol is less than what you get for, you know, if we're using the other beta blockers. There's another question here. I'm not sure I really understand. It said, can I clarify on why for blacks the BP target is still 130/80 for over 6 years, contrary to Gen Z 8? I saw. Not sure I understand.
The person who asked this question, could you clarify the question? Did you hear the question? Can Prof. Mbakwem clarify on why for blacks the BP target is still 130/80? Anybody claiming this question? Maybe they're shy. Okay.
No, but what I know is that, I mean, Gen Z 8 have taken off my radar, because I also, I mean, like the people who wrote the Minority Report had said, it was going to negate all the benefits we had with blood pressure management. Remember, they had pushed the threshold for treatment, you know, higher, targets higher. And we're saying, no, you know, these complications happen at even much lower blood pressures. Why are you saying that? And then Sprint followed after. Actually now pushed it much lower, you know, so, I mean, GSC 8 has been laid to rest. So I don't think we should be.
Okay, I like this question. I'm not going to answer, but I like to read it out because it's an important question. I know a patient who is on only Moduretics and his blood pressure is controlled. Is this okay? Because I heard it might not be advisable to place a patient on only Moduretics.
Please profile this patient properly. Remember, we're saying we are not just looking at the numbers. Your aim is the total cardiovascular mortality and morbidity, the outcome you're looking at. Okay, so you're just using Moduretics, or the blood pressure is down and you're activating all the metabolic activation, maybe the pulse is also racing, and then somewhere along the line, you know, a cardiovascular event happens. And we're saying, okay, but the blood pressure had been controlled all along. So it's not just about the numbers plus all the other things the person is bringing on board. Remember the chart I put up, the ESC chart of risk profile. So the person who has a normal looking blood pressure may actually be at a high cardiovascular risk, you know, profile because of all the other things that are added onto the you know, the mix. You know, sometimes when I'm with the medical students and they're wondering, somebody comes in with 140/90 and goes home with about 3 or 4 medications. Another person comes in and goes in with 2. So it's like we're throwing calories and deciding what a patient gets. But if you've properly evaluated the patient and, you know, risk profile them, then that gives you the grounds and in a better standing to choose what that patient, but I wouldn't leave any of my patients on diuretic alone in this century. That's not possible.
I can safely say I have never prescribed diuretic.
Okay, there's a question about drug interactions of bisoprolol with other medications like analgesic, and also the safety of bisoprolol and beta blockers in subjects with comorbid conditions, like, for example, diabetic patients treated with insulin or other hypoglycemic medication. So, but let me just continue this issue of safety and dosing of bisoprolol in dialysis patients. So if you have a patient who is already on bisoprolol, there's no need to modify the dose. But however, if you want to start the treatment in patient who is on renal replacement therapy, you have to start with the lowest dose, even 1.25, okay, and then up titrate slowly. So let's go back to this interaction issue. Fortunately, bisoprolol has no any specific pharmacokinetic interaction with other medications, at least to my knowledge. I also quickly checked in the drug and drug interaction database. However, when you have someone on bisoprolol, you have to be aware that it may potentiate the action of other drugs like hypertension in, for example, in males on alpha anti-adrenergic drugs like people with BPH, or if you have someone on amiodarone, it may, combination with bisoprolol may induce bradycardia. So these interactions are mostly related to the major therapeutic effect of bisoprolol, like reducing heart rate and lowering blood pressure. So in case you administer a drug that has similar activities, you may expect, or you should be very cautious and watch for these kind of adverse events. When it comes to diabetics and treatment of insulin, there was always a fear and great danger of episodes of hypoglycemia. And this was based on two assumptions. First, release of glucose from glycogen in the liver is stimulated by beta receptors. So when you treat someone with beta blockers, you may expect that during hypoglycemia, the patient will not release her or his own glucose. With cardioselective beta blocker, it's not the case. The second point was that, of course, you may have insulin resistance due to beta-1 blockade. Also with cardioselective, it's not the case. There are data in patients treated with cardioselective beta blockers that show that, for example, OGTT, glycated hemoglobin, fasting glucose are on the same level during the treatment. However, there were also fears that, for example, if patient develops hypoglycemia, these symptoms can be masked by the treatment with beta blockers like tremor, tachycardia, or sweating. Again, with highly beta-1 selective, it's not the case. So for patients with diabetes, cardioselective beta blockers treated with insulin and a hypoglycemic drug, these drugs are absolutely safe.
Okay, thank you. Has anybody got any questions or comments on the floor? Okay, anyway, you guys did well, so they're going to allow us to eat. All right. This cameraman, please stop showing. I'm just finding out from your angle that there's some deficit here, so please stop showing it. All right, can we have some short closing remarks from our two guests? I'll start with the lady first.
Well, I'd like to appreciate Merck for bringing us all here, for coming to learn, and for bringing Concor AM. for me, it increases the spectrum, for me to choose from when I'm looking after my patients, but like I keep stressing, the starting point is proper profiling of that patient. And that directs you to what the patient will need or will not need. I mean, we've gone past the level where one size fits everybody. We know that every hypertensive is a different person, is a different individual, and comes with his own baggage, to the table for discussion. And please, let's take those into consideration. And I can't leave this meeting without talking about communication. I know Prosamira will just be dancing on her chair, communication. A lot of the time, most of the time, the patient don't understand what we are talking about. And we want to, kill them for not adhering. When we are talking over their heads, we are using all the technical jargons, where, we need to get them on board. They need to understand why they need to pop those pills. Let me ask a question here. How many of us in this hall has ever finished a course of antibiotics? Please raise your hand. A course of antibiotics. Raise your hand. You are health professionals. It's less than 2%. Exactly. Dr. Emi said that once the symptoms go, they stop. But this man or this woman doesn't have any symptoms. And every morning I expect him to open his mouth and pop pills. It's a difficult task. And those patients will take a drug holiday, any which way we want to take it. Please don't kill them. Don't shut the door. Leave the door open. When they take those drug holidays, they will tell you. But when you are too self-righteous and you shut the door, they won't tell you. My patients are very smart. A week they stop the medication, a week to clinic time, they will start again. Because they know my first question will be, have you been taking your medication? And they'll say, yes. That's okay. For how long? Actually, doctor, I wasn't on it from, But please, let's use ourselves as an example. And the worst patients you can have as hypertensive patients are doctors and nurses and pharmacists. They're the ones that will give you the most trouble because they won't take their medications. Thank you.
Okay. Basically, you said everything. So there's nothing to add. But from my side, I would like, first of all, express my gratitude and thanks for opportunity to be here. This was a fantastic meeting because we are partners. It's not the situation teacher and student. We are just partners, exchanging our opinions and sharing our knowledge. And I do value this kind of meetings. And just briefly to go back to the major point, I think it's time to change our clinical thinking. When it comes to high blood pressure, we have to accept that we need to use fixed dose combinations from the very, very beginning. You have a new one at hand, which is effective, which is safe, and it also offers specific advantages in many groups of your patients. But again, thank you very much.
Okay, thank you. I don't have much to say, but I'd like to say we students, we should all give ourselves a hand. I think we did well. Yes. I would like to thank our teachers for what they've given out to us today. I have one thing about hypertension that you should, if you come across patients whose blood pressure, they're on 3 drugs, their blood pressure doesn't come down. I have found out that one of the commonest causes is ECPA, groundnuts. I only found out last year that groundnuts are fried in salt. Yes, so those of us who didn't know that, ask your patients. And I can tell you 60% of mine, when I ask them, you take groundnuts, they look at me. Is that a problem? I say, yes, so it's a problem. So just remember, groundnuts are a very common source of unexpected salt intake. And then I'd like to thank Merck. This was a beautiful program. And I hope we enjoyed the meal afterwards. Yes, give Mark a big hand. This was a nice program. They're going to talk. I'm very interested in talking about the food, but I'll leave it up to them. All right. Cameraman, no higher foot in my head.
So I will take us about 2 minutes to thank the speakers. I'll thank Professor Gassion. It's good that you are in Nigeria today. And we hope you come back again. And thank you for having a very good impression of our country. I'll thank Professor Mbakwem and Dr. Yemi Johnson. I know it's very difficult for you to find time, and thank you for staying all this length. It shows the kind of commitment we have for the patients. So for all of you, Professor Akbar, thank you for coming. I know the flight was not easy, but thanks for being here. And thanks everyone. I wouldn't mention your name one by one. We are very happy that you're with us today. Please, we'll ask you for our memory to please join us. Let's see whether we can have a group photograph. And after which, please, we can have our, it's no longer lunch, this is 5, maybe early dinner. And I think that's also what the experts recommend, that we should eat early so that it will digest and we can burn it away. So I'll invite you to please come. Let's see how we manage, take a photograph, then we can have our food, sit, eat, and then we can leave. So from all of us at MEC, it's our great pleasure, and we say thank you very much. We'll do this for our patients. As you go home, you have heard the message. Let's care for our patients as much as we can. That's why we're in business. Thank you so very much.
Multiple systems.
Yeah, clap. Yes, that's good. That's good. All right. On a serious note, at 20:00, Poland is playing Argentina. Poland has 4 points. Argentina has 3. All Poland has to do is draw, and they're through. So let's. How do we shout for that? Let's pray for them that since Prof is here, let them at least draw. Right.
Jerusalema ikayalami ilondoloze uhambe nami zungangishilana Jerusalema ikayalami ilondoloze uhambe nami zungangishilana dawo yami ayikholana buso wami awukholana ilondoloze zuhambe nami dawo yami ayikholana buso wami awukholana ilondoloze dawo yami ayikholana buso wami awukholana ilondoloze zuhambe nami dawo yami ayikholana buso wami awukholana ilondoloze Jerusalema ikayalami ilondoloze uhambe nami zungangishilana Jerusalema ikayalami ilondoloze shilana